Good evening, everyone. Thank you for joining our online CME live today from Gleneagles Hospital, Kota Kinabalu. My name is Lucy, and it is with great pleasure that I welcome everyone to our online CME live event, especially to those who have followed and support us from the beginning. Today we have Dr. Sreetharan Sundaram, our resident ear, nose, throat, head and neck surgeon, to share with us on overview of sleep disorders and the management of obstructive sleep apnea. For your information, Dr. Sreetharan is also the Medical Director of Gleneagles Hospital, Kota Kinabalu. Before we start, allow me to brief you a little of Dr. Sreetharan's background. Dr. Sreetharan obtained his medical degree from University Malaya in 1996. He qualified as an ENT surgeon from University Kebangsaan Malaysia in year 2004. He was awarded the Mar Hakim Award for the best student in the final examination. He obtained a postgraduate diploma in aesthetic surgery from University of London in 2009. He obtained a master's in sleep medicine from the University of Oxford in 2018. He has practiced in many hospitals and has published numerous articles in local and international journals. If you have anything to ask Dr. Sri, please send it to the comment section, or you can WhatsApp your questions to the phone number as stated below. And Dr. Sri will try to answer your questions towards the end of our session. Without further ado, I will pass this session now to Dr. Sri. Good evening, Dr. Sri.
Hi, good evening everyone, and thank you for taking the time off on a Friday evening to listen to this webinar. I hope that this webinar will prove to be useful. So today what we're going to do is just have a simple overview of sleep disorders, and we will zoom in and focus more on obstructive sleep apnea. So this is how we will go about it. First, I will talk about what is normal sleep. Then we go into the types of sleep disorders, how do we diagnose sleep disorders, and then we will focus on obstructive sleep apnea diagnosis and management. Now, I'm sure some of you all would have thought about it. Why do we sleep? Do we really need to sleep? Why can't we go 24 hours without falling asleep? We know that sleep sleep is a common thing among all animals, even the lower life forms and higher life forms. All animals have a period of inactivity or sleep. So it does mean that sleep must have there must be a biological reason why we sleep. So these are the postulated reasons for sleep. One, there is a restorative function. So during sleep, which is a downtime for our body, that's when there is a growth hormone induced tissue repair and protein synthesis. And also sleep is a period of energy conservation. If you spend the whole day working, foraging for food and trying to survive from being hunted by other animals, then you will need a time for energy conservation. That is your sleep time. Sleep also enhances immune regulation, and sleep is important for the brain maturity, which is why infants and children actually sleep a longer period, and this longer period of sleep is required for the maturation of the brain. And memory consolidation, one of the most important reasons of sleep. I'm sure most of you all would have experienced it, that you find that if you need to prepare for an exam or you work and then you study and you sleep, and you find that you retain your information a lot better after sleep. And synaptic hemostasis, what this means is when we experience things during the day, the brain forms all the information goes into the brain, and then there are synaptic connections. So during the night there's a process of pruning. So the important connections are strengthened, the unnecessary ones are pruned. So that is how you form memories. And there's also a lymphatic system in the brain. We call it the G lymphatic system. It helps to cleanse the toxins out of the brain, especially things like amyloids. So these are the postulated purposes of sleep. So this is the neurobiology of sleep. What are the systems in the brain that initiate sleep and wake? Now the wake areas in the brain are from the locus coeruleus, the median raphe, the tuberomammary nucleus, and the neurotransmitters involved are the noradrenaline, serotonin, histamine. So these are the wake promoting areas. The sleep promoting area is actually the ventrolateral preoptic nucleus, and the neurotransmitters involved is GABA and ghrelin. Whereas this side, the pedugopontine or laterodorsal tegmental nucleus is the part of the brain which is involved in the REM sleep. So we have a biological clock in our body. This is called the circadian rhythm. So circadian means a 24-hour cycle, but actually in humans, the circadian rhythm actually varies in different animal species, but in humans it's actually 24.2 hours. So your brain is automatically programmed to go to sleep at night. So for example, let's say at 9 p.m. actually, when your melatonin secretion, which is the sleep promoting hormone, starts around 9 and you go to sleep, you go into your deeper sleep around 2 a.m. and at 4 p.m. you have the lowest body temperature at 4 a.m. Then you start waking up, and when you wake up is when your blood pressure kind of shoots up, which is why a lot of cardiovascular events happens at this time. Then the melatonin kind of stops once you're fully awake, and you have your highest alertness at about 10 a.m. and your best coordination is supposed to be at 2:30, and your fastest reaction time is around 3:30, and your greatest cardiovascular strength. For this is just a general rule, but this is how your body's biological clock works. And what controls the circadian rhythm? You already have an inherent circadian rhythm, and this is strengthened by exposure to light. So when you're exposed to light exposure, especially the blue spectrum of the light, stimulates the melanopsin expressing retinal ganglion cells. These send signals via the retinohypothalamic tract to the suprachiasmatic nucleus, and that sends signal down to the cervical ganglion and up again into your pineal gland, where it suppresses the secretion of melatonin. So light suppresses melatonin. So at night, when there's no more light, your melatonin secretion goes up, and that helps you to fall asleep. So this is how the circadian timing works. You have exposure to light, the retinohypothalamic tract sends signal to the suprachiasmatic nucleus, and then you have outputs. So these functions of the human body is actually circadian control. Your temperature, cortisol secretion, melatonin secretion, sleep-wake cycle, behavior and cardiovascular function, all of these are under circadian control. So sleep is generally divided into non-REM and REM sleep. The bulk of your sleep is the non-REM sleep, which has got about 3 or 4 stages. The third and fourth stage are the deeper stage, and REM sleep forms only about a quarter of your sleep time. So when you sleep, you cycle through the sleep stages from the stage 1 to stage 2 to stage 3, then REM, then back to stage 1. Stage 1 is your light sleep, where your muscle activity slows down and you may have a little bit of muscle twitching. Stage 2, you go down into deeper sleep, so your brain does less complicated stuff, your breathing pattern slows down, your heart rate slows down, your body temperature drops. Then stage 3 and stage 4 is actually your deep stage, where your body makes repairs, where your brain generates the slower brain waves, and you have more rhythmic breathing, limited muscle activities. Then you'll move to REM sleep, rapid eye movement sleep. This, on the other hand, is when the brain waves speed up, so you have more active brain activities. This when you dream during the REM sleep, and you find that the heart rate actually increases then, but your muscles are still relaxed. Then from there you go back into the stage 1. This whole cycle takes between 90 minutes to 120 minutes. So in a night, you may go to 3 to 4 cycles. So you start off with awake, you go into stage 1, stage 2, stage 3 and 4, then you go back to stage 2, then you come up to REM sleep, then you go back again to stage 2, stage 1, back to REM sleep. So if you look at this graph here, you can see that earlier in the night you have the deeper stages of sleep, whereas later at night you have the longer periods of REM sleep. And I'm sure you can think about it, because REM sleep is where dreaming occurs, and often the most vivid dreams happen early in the morning. Okay, how much do we really need to sleep? So this is a general number. Adults basically you should sleep between 7 to 8 hours, but I mean different people do have different sleep requirements, but an average time frame would be 7 to 9 hours. Obviously the newborns need to sleep longer, hence as the children grew older the sleep time comes down. But if you look at this, you realize that what is happening these days is a lot of school going children actually are not getting enough sleep. They're not getting the 10-11 hours of sleep that they require. So that is where there's a shortfall in sleep time. Now, so the processes which drive sleep, what makes us fall asleep, there are two main processes. We call it the process S and the process C. The process S is a homeostatic sleep drive or sleep pressure. So basically sleep occurs naturally in response to how long you stay awake. The longer you stay awake, the greater the pressure builds up for you to want to sleep. Whereas the process C is your circadian rhythm, your internal biological clock. So when as you approach night, the clock itself is going to trigger a sleep, will make you sleepy and make you want to go to sleep. The timing is regulated by the circadian biological clock, which is located in your suprachiasmatic nucleus. So this is how the process works. See, the upper graph here is your homeostatic sleep drive. So when you wake up in the morning, then as you proceed throughout the day, the pressure to sleep builds up until you fall asleep. When you fall asleep, the pressure drops down dramatically. Then you wake up the next day, it builds up. In the same time, you also have the circadian rhythm. So this is the internal biological clock. So that also coincides. So that it also drops at night. It coincides with your drop in the process S. You see, the process S is believed to be due to accumulation of certain substances in the brain which drive sleep, which increases the sleep pressure. And one of these substances is actually adenosine. So how coffee helps you to stay awake is because caffeine is an adenosine receptor antagonist. So as adenosine builds up, it acts on the receptors and makes you feel sleepy. So when you take coffee, it antagonizes the receptor. That is how caffeine helps to reduce your sleepiness, at least temporarily. So what happens when you don't sleep? So the effects of sleep deprivation can happen in your immune system, in your central nervous system, and your pancreas, heart, muscle. In the central nervous system, you will have cognitive impairment, memory loss, impaired moral judgment, impaired moral judgment, severe yawning, hallucination, and overall many of the symptoms are similar to ADHD. And then you have immune function dysregulation, pancreas, the pancreas increases the risk of type 2 diabetes. You can have cardiac arrhythmias, you can have a risk of heart disease, you have muscle aches, tremors, decreased reaction time, other things like growth suppression, decreased temperature, and risk of obesity. In the medical line, studies have shown that among medical professionals, as hours of sleep, nightly sleep decreases, there is 30% chance of more serious medical errors, 5 times more greater risk of diagnostic errors, and 61% more needle stick injuries. So clearly sleep deprivation in medical professionals is not a good thing. So there is also a link between sleep deprivation and obesity. It is postulated that when you sleep deprived, you have increased hunger because the hunger promoting hormone ghrelin goes up, and then the hunger suppression hormone leptin goes down. And also because you stay awake longer, you have greater opportunity to eat. So there's increase in caloric intake. Additionally, there's altered thermoregulation, increased fatigue. All of these causes reduced energy consumption. So you have more calorie intake, reduced consumption of calories, so you lead to obesity. There's also increase in stress hormone release. So let's talk about the type of sleep disorders. The International Classification of Diseases has listed out quite a lot of sleep disorders. They are under broad categories with many subdivisions under them. Basically you have things like under big categories you have insomnia, sleep-related breathing disorders, central disorders of hypersomnolence, circadian rhythm, sleep-wake disorders, parasomnias, and sleep-related movement disorders. Like obstructive sleep apnea falls under the sleep-related breathing disorders. So this is an example of circadian rhythm disorder. We call it a delayed sleep phase disorder. That means these are individuals where their circadian clock is actually timed at the later period, which means their biological clock only allows them to fall asleep later at night, say maybe 2 a.m. and then they wake up at 10 a.m. in the morning. This is how their biological clock works. So with these individuals, obviously if they are in a position where they don't need to wake up in the morning, and let's say they only go to work at noon, then it's not a bother for them. But in most people, schooling children and adults who need to work early, then it becomes a problem. So it is only symptomatic when forced to wake up early, and for these people, the treatment would try to be to shift the circadian rhythm back. We call it advance the circadian rhythm earlier. So one way you can do it is to give melatonin at the earlier time at night to bring the rhythm earlier. Plus, when they wake up in the morning, you expose them to this bright light. They have these devices, they call this it produces very bright light, about 3000 candela, and this helps to shift your circadian rhythm earlier. Another very common disorder is insomnia. So the insomnia can be either difficulty in initiating sleep, difficulty in maintaining sleep, or early morning awakening and difficulty going back to sleep. And people with this insomnia have daytime sleepiness, inability to nap, and they have daytime impairment. They have difficulty with memory, concentration, attention. They constantly worry about sleep. They have mood disturbance and irritability. It is estimated that at least 10 to 15% of adults are affected. And the prevalence of insomnia increases with age and is more common in women. To diagnose it is basically by history. And sometimes you give them a sleep diary where they record how many hours a day they sleep and what time they fall asleep, what time they wake up. The gold standard for treatment of insomnia currently is cognitive behavioral therapy. Hypnotics is only an adjunct. The thing to remember is insomnia is a disorder of arousal. That means it's a hyper-arousability. That means the person is always aroused. They cannot go to sleep, which is why often these people, despite sleeping so little, they're not like for example, in OSA, you see them dozing off, falling asleep during the day. Whereas those with insomnia, even though they don't sleep enough, you don't see them actually having that sort of sleepiness. But they are irritable, they don't unable to concentrate. They will exhibit all the other symptoms of lack of sleep. Another very rare disorder is called narcolepsy. It's very rare. Prevalence only about 0.02%. These people, they have this dramatic condition where you will see them talking, sometimes they'll be laughing in a family gathering, and then suddenly they will just collapse and fall down. So it's called a cataplexy, and they will have hallucinations upon falling asleep or awakening. So this diagnosis is a bit, so the pathology in these people is that there is a particular hormone, part of the brain which secretes a hormone called hypocretin. Hypocretin is a hormone which is important to maintain your wake state. So when you don't have that, you can't maintain your wake state and you tend to fall asleep. So they have a deficiency in this hormone. So the diagnosis is by polysomnogram and by multiple sleep latency tests. So in treatment of this condition, you give them stimulants, basically things to stimulate them during the day to keep them awake, by giving them modafinil or other stimulants like gamma hydroxybutyric acid or SSRIs. Another sleep disorder I think you would have heard of is like REM behavioral disorder. So these are people who basically when they sleep at night, they act out their dream. You see, at night when we go into our REM sleep, that's when you do most of your dreaming. You do most of your dreaming in REM sleep. But doing REM sleep, the brain is active, and you have this REM sleep sends a rapid eye movement, so you have this rapid eye movement. But the body also sends cholinergic impulses to completely relax your muscles so that you don't act out your dreams. But people with this disorder, that inhibition is not there, so there's muscle movement and they may act out their dreams. So the polysomnogram will show increased muscle tone rather than decreased muscle tone, and is more associated with Parkinson's disorders and other neurological disorders. It's more common in men and is treated with clonazepam or melatonin. Another disorder is what we call a periodic limb movement. So these people, when they're sleeping at night, they have periodic movements of their predominant legs, rarely the upper arm. So they have repetitive and stereotypical limb movement during sleep, predominantly the lower extremities. And so when you send someone for a polysomnogram, a sleep study, there's actually a index. They will tell you a limb movement index. A number of 15 and below is considered normal in adults. A number of 5 and below is normal in children. When it's more than 15 movements an hour, then it's considered abnormal. So those who have this movement will disrupt their sleep and cause them not to have a proper night's sleep. So it has to be treated. Usually we treat them with dopaminergic agonists. So now we come to obstructive sleep apnea. We'll talk about the risk factors, the pathophysiology, the diagnosis and treatment. This is a not uncommon disorder. It's characterized by repeated episodes of breathing cessation due to upper airway collapse. Now, see, when you sleep at night, you're breathing through your nose or maybe a little bit through your mouth, and then the air goes to the back of your throat and goes down into your larynx. So what happens is, if there is a narrowing of your air passage, you snore. But if there's complete blockage, is that when you have an apnea, you cannot breathe, and this is an obstructive apnea. So that's when you have the gasping and choking. So this can affect up to 2 to 4% of the adult population. The risk factors are middle-aged male, postmenopausal women, those with body mass index of more than 30, basically obese people, neck circumference of more than 15 centimeters in women or 17 centimeters in men, rhinognathia or micrognathia, and macroglossia, large tongue. So what the pathophysiology is that there is repeated obstruction at night causing hypoxia and repeated arousals leading to sleep fragmentation. This in the end will cause daytime sleepiness, poor concentration, depression, increased risk of work and work-related and motor vehicle accidents. And eventually they will have higher risk of cardiovascular problems and metabolic complications. So this is a kind of busy slide, but it gives you it kind of outlines the pathophysiology behind OSA. So the two main things that happen here is intermittent hypoxia and sleep fragmentation. So all the problems of OSA comes from this intermittent hypoxia and sleep fragmentation. So because of these two things, you'll end up having a sympathetic activation, increase in catecholamines, oxidative stress, systemic inflammation, hypothalamic pituitary axis activation, adipokine dysregulation. This leads to insulin resistance, B-cell dyscrasias, eventually leads to type 2 diabetes, and downstream of that you get further microvascular and macrovascular complications. Microvascular would be like retinopathy, nephropathy, neuropathy. Macrovascular would be coronary artery disease and peripheral arterial disease. And then obesity, OSA both causes obesity, and obesity also contributes to obesity. So it's a two-way street as regards to OSA and obesity. So those with sleep apnea would complain of snoring, excessive daytime sleepiness, gasping or choking during sleep, and they wake up in the morning, they feel their mouth and throat to be very dry. They have this morning heaviness and headache, and sometimes the bed partner will tell you that they have actually witnessed pauses in breathing, and it is often found common in those who already have hypertension, diabetes, or suffer from depression and insomnia. So these are the common symptoms that should trigger a clue that a person could be having OSA. One would be they have loud or irregular snoring, daytime sleepiness, unrefreshed sleep regardless of sleep duration, increased fatigue when the person is sedentary, nocturia, choking or gasping in sleep, dry mouth on awakening, morning headaches, body mass index of more than 30, crowded oropharynx, increased neck circumference. Sometimes has a screening tool. We use this questionnaire, we call it the stop bang questionnaire. So for each yes answer here you score 1. If someone has scores more than 5 or above, then they have a high risk of getting OSA. So the basic questionnaire is: do you snore loudly? Do you feel tired, fatigued or sleeping during the day? Has anyone observed you that you stop breathing or you choke or gasp at night? Do you have high blood pressure? Is your body mass index more than 35? Are you more than 50? Is your neck circumference more than 40 centimeters? Or are you male? This is another scale that we use to measure the extent of daytime sleepiness. It's called the Epworth Sleepiness Scale. So basically you ask them, how likely are you to doze or fall asleep in the following situations, where 0 is no chance and 3 is very high probability. So the situations would be sitting and reading, watching television, sitting inactive in public places, lying down to rest in the afternoon, sitting and talking to someone, sitting quietly after lunch without alcohol, as a passenger in a car for an hour without a break, or in a car while stopped for a few minutes in traffic. So a score of 10 and above would be considered to be positive. That means you have excessive daytime sleepiness. If your score is 16 and above, then you have very bad daytime sleepiness. As you can see, it's obviously more common in male. So now you're looking at this patient with OSA. You want to look at the clinical examination. So you look into the appearance, obviously whether the person is obese or not. Secondly, you look at the mouth. So the mouth is very interesting. If you see the jaw to be receding, so this is retinogasia, so that means that their airway at the back of the throat would be narrowed. Then you look at the mouth. This is a large tongue like this is called macroglossia. Then another simple thing we look for is you ask them to open their mouth and say, just open the mouth and stick out their tongue, and you look at the posterior pharyngeal wall. If when they open their mouth wide and they stick out the tongue, you can see the posterior pharyngeal wall, you can see the anterior tonsillar pillars, you can see the uvula and the soft palate. Then that's a score of 1, either Malapati 1, or we call it modified Malapati score, or Friedman score. So that's a score of 1. If when they open their mouth, you can still see the uvula but only partially, that means the tongue is elevated, you can see half of the uvula, a bit of the anterior pillar, then it's score of 2. But if you open the mouth, you hardly ever see, you just only see the beginning of the uvula and most of the anterior pillar is blocked off, then it's score of 3. Or the tongue is so high that you only see the hard palate, you don't see any of the soft palate, then the score of 4. So someone who has a score of 3 and 4 would have a high risk of having obstructive sleep apnea. Another thing you can do is you also look at the tonsils. It's a very large tonsils like this. This is called a grade 3 tonsils, where they're almost touching the midline. Then this would contribute to obstructive sleep apnea. Then you look at the nose, a deviated septum causing complete blockage of the nose on one side. That also can cause to obstruction. Obesity with really fat neck and a lot of fat in your neck, that also can cause obstructive sleep apnea. Then you put, if for ENT we put in the scope into the nose, like here for example, you see a deviated nasal septum that may cause a certain extent of blockage in that part of the nostril. Sometimes you see a nasal polyp, this also can cause a nasal blockage. Then we do another procedure we call a flexible pharyngoscopy, where you put a scope through the nose, goes to the back of the nose, goes down to the posterior pharyngeal wall and down all the way to the larynx. So this view here is the view of the nasopharynx. This is actually the eustachian tube, and from this is the soft palate. You'll be going down here. When you go down here, you see the tongue. This is the tongue, the back of your tongue. That's the beginning of the uvula. You go nearer, you see the uvula. So you can see how narrow the air passage is. So sometimes, especially in people who are planning for surgery, and you want to know which part of the anatomy is the narrowest and would be the which part actually you need to do the surgery to expand. So we induce sleep in them and do the same scope but induce sleep. So how we induce sleep is usually it's done in the operation theatre. We give them a propofol infusion, so they actually go to sleep, and we put in the scope and we examine each part of the aerodigestive tract to see where is the narrowing. So first we will look at the nasopharynx and the soft palate. This would be the view where you see the posterior pharyngeal wall and the soft palate. Then you go further down, you see the beginning of the tongue, back of the tongue here, lateral nasal wall. Further down you see the tongue base, again the lateral pharyngeal walls, and then all the way down you're looking at the uvula. So we will, once you have seen all this, and then we will document the degree of obstruction, whether it's non-partial or complete. And the kind of obstruction, is it the anterior posterior narrowing or a lateral narrowing or a complete circular narrowing of these areas, and from there you can determine which area might be surgically correctable. So the gold standard for diagnosing obstructive sleep apnea is a polysomnogram or a sleep study. It's a simple non-invasive procedure which is done at night, and what they record are your brain waves, the oxygen level, your heart rate, your breathing, your eye movement, leg movement, and it also documents the sleep stages. So they actually this polysomnogram is divided into 4 levels. A level 1 polysomnogram is a attended one, where you actually sleep in a sleep lab, and there's a sleep technician who sits there who's watching you throughout the night. So here there's a minimum requirement of 7 parameters, which includes EEG, EOG, chin EMG, airflow, respiratory effort, oxygen saturation, and ECG. Often there's also a video recording of your sleep. And in the level 2 is similar to level 1, only thing there won't be a technician in attendance. And usually in level 1 and level 2 sleep studies, you will be able to see your sleep stages, because you take your EEG, so you can know your sleep stages. Now the level 3 and level 4 are simpler sleep studies, which are often what we call a home-based sleep study. So in level 3 you need to record at least 4 parameters, which is the ECG, oxygen saturation, and respiratory efforts. And level 4 is only 3 channels. Now in level 3 and level 4 sleep studies, you do not have sleep stages. Now you may wonder what sort of sleep study would you need. Now if you have seen and examined a patient and you think this person has got a very high probability of having OSA, he has got all the classical symptoms, choking, gasping, daytime sleepiness, snoring loudly, looks obese, and he has got which in your opinion, high risk of having OSA, then sometimes a level 3 or level 3 study would be enough to come to a diagnosis of obstructive sleep apnea. However, if there's more than one thing going on, they may not just be having OSA, they could be having a bit of insomnia, they could be having other sleep disorders. Then you want to know the sleep stages, you want to know whether they have movement and sleep, then you will need to do a proper level 1 sleep study. So when you do this polysomnogram, you will get a score. It's called the Apnea Hypopnea Index. Basically what it means is that how many episodes of apnea and hypopnea you have in a night. A score of 5 and below, how many episodes of apnea, hypopnea you have per hour of sleep. A score of 5 and below is considered normal. 5 to 15 is mild, 15 to 30 is moderate, more than 30 is considered severe. So once you get the score, then you can start thinking about treatment. If a person snores but the score comes to below 5, that means they don't have OSA, they just have primary snoring. So then you will give them advice of weight reduction. Sometimes they find just sleep on the lateral position, they may snore less. So that's just advice about snoring. If they have mild sleep apnea, they have mild obstructive sleep apnea, that means a score between 5 to 15. So now at this level, mild, you may choose not to sleep if they are not really symptomatic. They don't really have much daytime sleepiness, they seem to be well adjusted. You may choose not to sleep. However, someone who has got mild but is symptomatic, they complain of gasping, poor sleep, they're having daytime sleepiness, or they have other medical disorders like hypertension, diabetes, then you may want to treat them. But anything more than 15 is treated. So moderate to severe sleep apnea is usually treated, and the standard of care is to treat it with CPAP, continuous positive airway pressure. There's also other alternative treatments like oral appliance, positional therapy, or surgery. Now, how continuous positive airway pressure CPAP works is that it functions as a pneumatic splint. Remember, in obstructive sleep apnea, the airway collapses when you sleep at night. So when it narrows, you snore. When it collapses, that's when you have an apnea. So what you do when you put the CPAP device, it pushes a column of air in and opens up the airway. And this maintains the patency of the airway and stops it from collapsing. But for it to work, the person has to use it at least 4 hours a night and at least 70% of the nights. So compliance is important. Nowadays, the device that we use is what we call an auto PAP. That means the machine itself, actually can adjust the pressure to push in according to how much you require. So when a person with severe OSA, when you start them with the CPAP, then they will actually get immediate benefits. There will be reduced sleepiness, increased vigilance, enhanced productivity, improved driving performance, increased tolerance of physical activity, reduced risk for stroke and hypertension, improved blood pressure control, improved ejection fraction, greater endurance, increased respiratory capacity, reduced airway reactivity, reduced risk of type 2 diabetes, and possibility of reduction in insulin resistance. So this is how it looks like. It's basically a mask, and it's going to pump in the air to splint open your airway. It's either just a nasal mask or a full face mask. As you can see this, obviously it'll take some time for you to get used to it, and there's some people who do find it difficult to tolerate using the CPAP mask. Another alternative treatment is we call a mandibular advancement device. So these are the patients where you see the mandible falls back, the tongue falls back and obstructs the airway at the back. So you put this device where there's a custom-made device. It's like it's molded to your teeth, and then there's metal things which forces your jaw to go forward, and that opens up the area at the back. So it's a viable alternative to patients with mild to moderate OSA intolerant to CPAP. That means they can't tolerate CPAP, they want another option, you can offer them this. It is a safe treatment, but there are some mild short-term side effects like excessive salivation, dry mouth, and gingival irritation. There are also more persistent side effects like arthralgia, teeth pain, and occlusal changes. Treatment success is usually higher in those who are younger female patients, non-obese, non-position, and milder OSA. But those who already require high CPAP pressure usually won't work very well with them. Surgery is another alternative in OSA. In the pediatric age group, often adenotonsillectomy alone will do a job, especially those are big tonsils, big adenoids. When you remove it, it dramatically improves their symptoms. Other surgeries that we offer in adults, we can offer tonsillectomy, septoplasty, turbinectomy, radiofrequency ablation of the soft palate and tongue base. Uveto-palatopharyngoplasty, U3P used to be a very popular surgery at one point, and there are many variations of it. But the rate and efficacy is found to reduce with time, and there's quite high complication rate of velopharyngeal insufficiency, dry throat, and swallowing difficulties. So these days it's not done as often, but in carefully selected patients it can still play a role. There are other procedures, for example on the tongue base, such as partial resection of the tongue, suspension of the tongue, and these can improve in selected group of patients. And another more dramatic surgery is called a maxillomandibular advancement, where you actually fracture your maxilla and mandible here, and then you advance it. This will really open up the pathway at the back of your pharynx, and for selected patients again it can work very well, but it's a major undertaking. And we also find that those who are obese, who have OSA, who go for bariatric surgery, there is an improvement in their OSA, but sometimes the improvement is not good enough that they can go off their CPAP. They do improve, the CPAP pressures may come down, but they may still need to be on the CPAP machine. So surgery, often you need a multi-level surgery. It is, is usually offered to people who cannot tolerate or refuse to use CPAP. So which means that for symptomatic OSA patients, those are moderate and severe, the first line is still CPAP. Only those who don't want CPAP or cannot tolerate CPAP, then we look for alternatives for them. That is how we offer them surgery. The reason being, sometimes surgery can improve the AHI score, but it may not come back to normal. Say for example, someone has an AHI of 70. When you do a surgery, the score improves to 30. That means they've increased dramatically from 70 to 30, but 30 is still severe, and they may still need to use the CPAP machine. So that is why we are quite selective in who we offer surgery to. So this is basically the flow for dealing with OSA. You treat the obesity, you look for any other abnormalities that can be corrected, like craniofacial malformation, enlarged tonsils, or nasal. Sometimes those have very bad nasal blockage, you can treat them with nasal decongestion, or sometimes surgery can improve that. And for everyone else, it's CPAP treatment. If it's successful, then they need to be on it long term. If it's unsuccessful, then you have to re-evaluate. Sometimes they can't use CPAP because the mask is not right, you can offer them a different mask. often you see it's like CPAP is like any other chronic disease. When you have diabetes, hypertension, you're on long-term medication. CPAP is a long-term thing, so there's issue with compliance. So you just don't put them on the mask and put them on CPAP and forget about them. You need to see them. You need to make sure they're compliant. You need to encourage them to use the CPAP machine as often as possible. Okay, so I think that is about it. We have more or less completed. So do you have any? I think we can take questions now.
Thank you so much, Dr. Sri, for the updates. We have received a few questions from our viewers today. First one will be from Dr. Ko Leong Hin. Why is melatonin banned in many countries? It is over-the-counter items.
Yes. See, the melatonin. There are two ways to look at it. When you give it at a high dose, I mean, when I say high, it's about 3 milligram. It functions as a hypnotic. It's like any other sleep medication. But when you give it in a lower dose, it's meant to regulate your circadian rhythm. And the thing about melatonin, for it to function to regulate your sleep, the circadian rhythm has to be given the right time at night. Remember, I showed you that the circadian rhythm, where the natural melatonin, melatonin secretion starts around 9-10 at night. Then it reaches a certain peak, then it drops by 6 or 7 in the morning. So if you give melatonin at the wrong time of the day, it doesn't help, it may make things worse. Yes, in a lot of countries it's used like a OTC medication. I think in Malaysia we haven't reached that stage yet. But it is pretty harmless, and actually when it's used as a hypnotic, it's actually not a very strong hypnotic. That means it's not if you're using purely as a sleep medication, it's not that strong. Actually, you'll find that most of the other ones that you have in the market, the zolpidem and all that, will work a lot better than melatonin. If you don't use it purely for as a sleep medication, then it is not the strongest sleep medication around.
All right. Next one. This one is also from Dr. Ko Leong Hin. CPAP face mask does not look comfortable at all. How can the patient toss and turn during sleep, doctor?
Well, it is difficult. So I just showed you one example, but nowadays there are a lot of, if you go ahead and look at CPAP face mask, now there are a lot of fancy versions. They have these tinier ones. It's like a pillow thing, just a small plastic thing sticks on your neck like a pillow. It is advanced. That is just the earlier generation. There are many different sleep masks. So what happens that you would find something that fits for the patient. Usually when they have a device, the company that gives it will give them various options to try. Eventually they may find something that is works for them. But it's also true, there are some, they really cannot get used to it. So what happens actually is like this. If you have very bad sleep apnea, you really snore badly, you don't sleep, and in the daytime you really feel tired and fatigued, when you put in the CPAP, as uncomfortable as it is, you suddenly sleep well and you feel refreshed in the morning, and you feel so bad, you feel so alert during the day that you would be willing to put up with the discomfort of the CPAP mask because it makes you feel better. However, with those with mild or moderate thing, then the discomfort of the mask may outweigh the benefit they get from using CPAP. Then they may not want to use it. So that is why we find that those with severe CPAP, they can live with the discomfort of the mask because it makes them feel so much better.
All right. Next one, doctor. This one is from Dr. Nagaratnam. Dr. Sreetharan, what is your opinion of interrupted sleep, but the total amount of sleep for the day is about 8 hours? Will these patients be considered insomnia? Is afternoon nap beneficial?
Okay. So ideally, you need to have a solid block of sleep. You need to sleep within the 7 to 9 hours. So you see, remember what I showed you about the sleep cycle, how you cycle from stage 1 to stage 4 to REM sleep. So everyone needs a certain, it's the stage 3 and stage 4 sleep, which is the deep sleep. And that is where most of your brain function happens. The plasticity, the memory function, all happens during the sleep. And if you don't sleep for enough length of time, you don't even go into your REM sleep. Remember, REM sleep only comes after falling asleep for about 1 to 1.5 hours. So if you're going to have a 1-2 hour sleep, 1-2 hour sleep, then you find you are not actually getting a full sleep. You only maybe sleeping at stage 1, stage 2. You don't go into deep sleep, you don't get REM sleep. So that is not why it is not advisable. Ideally, you should sleep one complete block. You sleep for about 7 to 9 hours, and that's that. And there should be no need for a daytime nap. So you need to cycle through the the cycles, the 4 to 5 cycles of the natural sleep cycles to get the full benefit of sleep.
Okay, all right. So, Doctor, that was the last question we have for today. Dr. Sri, do you have any last remarks for our viewers today?
I think it's okay. So, I hope I have helped to sort of demystify sleep and sleep disorders and clarify some of your questions on obstructive sleep apnea. It is a manageable disorder, but it's like most disorders, it's a chronic disorder. You will need to, it's not just about doing a sleep study, giving them a CPAP and then forgetting about them. You will have to follow them up, see whether they're compliant, look at the benefit they're getting. Sometimes they may feel it doesn't work, then you tell them, okay, never mind, we can try other things. There are other options. Sometimes we can try surgery or other things to help them if they really can't use the CPAP.
Okay. Thank you once again, Dr. Sri. To all our viewers, please don't forget to scan the QR code at the end of this live by using your MMA Doctor phone application to get your CPD point now. If you have any difficulties to scan the code, please click on the link in the comment section to confirm your attendance manually before 8 p.m. today. And also, we have another online CME session with our resident infectious disease consultant, Dr. Timothy William, on the topic of the hope and fear of the COVID-19 vaccine on 11th of March at 6 p.m. Let me know if you are interested. We will share the details with you. We have come to the end of our online CME today. Thank you very much for watching us and see you next time.